So you may say that maybe just Americans are just bad surgeons compared to Indians because we need help. Or maybe we're understanding that there's a lot of mistakes you can do in osteotomy. And I learned about slope the hard way. I remember one of the first osteotomies I ever did opening wedge. He had a prior meniscectomy, a state trooper. Did great for 5 years. I increased his slope by 6-7 degrees. Didn't bother him until he tore his ACL. He didn't know that was from the osteotomy. I got another operation out of it. I fixed his ACL, but that's when I really learned about slope, and that was about 15 years ago. So what's the next frontier of osteotomy, right? First was the coronal plane. Now sagittal plane. Then we're going to deal with tubercle. And then we're going to deal with version, with REC. And that's really how this procedure is really going. So this is what I was saying you before. We know a lot more about slope. And we know a lot more about ATT. Actually, I think ATT is probably more important than slope. And the best way we can manipulate anterior tibial translation is by manipulating slope. This is a recent meta-analysis that we did. And it's convincing that slope-changing osteotomy works. It can dampen an ATT, and it can control instability. I did this when I was a resident with Dr. Warren. We asked who does lateral closing wedge. Well, the reason to do lateral closing wedge, besides a smoker, is actually to decrease slope, because it's much more predictable to decrease slope with a lateral closing wedge than an opening wedge. And this was an award paper. It's about twice in one. It's very hard to dampen slope with an opening wedge more than 5 degrees, versus it's very easy to do because you can make an asymmetric wedge with a lateral closing wedge. But regardless, they're both very effective in controlling slope and even a little bit of the pivot as well. We also showed that a small anterior lateral hinge or an unstable hinge, the more you make the hinge unstable is the only way you can decrease slope, which makes sense, right? You have to cut the posterior lateral tibia. And the reason why most people increase slope is they get afraid with the saw in the back of the knee. They keep the bone here and they accidentally increase slope. But if you want to actually really decrease slope, you actually have to take a picture of an osteotome fully out on your AP x-ray out laterally, which you normally would be scared by that. We even showed another paper, the only way to really, really dampen slope is to make really extreme anterior lateral hinges. So this gray line is your slope neutral osteotomy. That's your hinge axis. So when I taught osteotomy, I never knew what the word hinge axis. We invented this word to show that with smaller or more oblique hinge axis is the only way you can dampen slope. And the only way you can do that actually is with big coronal correction. So there's no way to really change slope unless you want to change the coronal correction greater 7-8 degrees. If you want to just take 1 or 2 degrees out of slope and only have a 2 or 3 coronal correction, you can't do that. Which begs this concept of where sagittal osteotomy or pure sagittal came from. Now, we were just told by Nilesh, one of our friends, saying that my old teacher, Chris Harner, he goes, if you drill the saw A to P, you're more likely to hit the artery. Wow, that's a paper that really needed to be made. But yeah, it makes sense, right? I always tell the residents, you want to drill medial to lateral. How do you do a sagittal osteotomy, right? Sachin can do it. Al Gecko can do it. They're not American. Us Americans, we're not smart. Or we get sued more. But they drill A to P, right? What did we design with BodyCAD? No, we designed a guide that sits on the medial tibia, and you drill medial to lateral, and you have this hinge pin here. It's just like, so you have a very stable construct, and you're not worried about it all. This takes the sweat of doing a to P cut and a very imprecise cut and a very hard cut to make it very simple. And it's really how PSI really makes slope-reducing osteotomies really simple. Because this is how I used to do it, and it's really, really hard to have these asymmetric wedges and these small anterior lateral hinges. And you better have good fixation. and you will have and you better think about using a hinge screw, staples, or something like that. It's a very hard osteotomy to do. So here's a guy, 5-degree slope, PCL deficient knee. This is the easiest osteotomy I ever did because I can always increase slope, right? Taking it away is a harder thing to do. So this is a patient that had a coronal osteotomy and ACL, failed. So he had an ACL and an osteotomy, failed, and then look what his ATT is here. This knee is skipped. He actually didn't have that much slope. 15 is kind of an overstatement. He probably had more like 7. But even with that ATT, we planned a sagittal osteotomy, a pure slope-changing osteotomy, and we went from 15 degrees to 15 millimeters to 5. Maybe even reverse the slope a little bit. So this is a powerful tool, and you need more accurate instruments to do that. Here's another one, 20-year-old female, left knee pain, failed ACL. Again, another example of the pure sagittal osteotomy. Just because I'm over, I want to get to tubercle quickly. So this is something that we've just designed. It's literally just being FDA approved right now. And the reason why is that tubercle osteotomies, again, are all based like this. Take your thumb and you go, oh, I'm going to anteriorize this, medialize that. It's completely conjecture, and there's so many complex parameters between patella height, medialization, anteriorization. There's a lot of stuff. Forget about even version. And we know that there's so many other variables. So I don't want to do all my, Rick said it best, I want to do all my thinking before I get to the OR. So we invented using our PSA guides, and there's other systems to control this. So here's an example of a PSA guide system. This is our templating, where we can template our cut, template our how much anteriorization, medialization, how much distalization. We also can do a good chamfer cut. So I used to do when I distalized, used a step cut, and those never healed. So now with the bone model, with the guide, it's a beautiful flat line, so you get much more bony surfaces to heal. And you have multiple parameters to do your TTO planning. And you do that virtual osteotomy, and your fixation is built into the plan. So off your guide, your drills are all pre-drill hold. Here's an example of a case. This guy had a lot of femoral version, so we did a femoral derotation osteotomy and a tubercle with distalization. Here's another really complicated case. This is a lady that failed the tubercle osteotomy and MPFL. She then failed a derotation on her femur and her tibia. So my limb lengthening guy sent her to me and he goes, hey, can you do this? And I was like, okay, well, this tubercle's been cut once. Her residual TTTG was still 20. Her femoral anteversion was normal now. Her CDI was still a little bit up. And I had an old drill hole, so I wanted to have a really fixed guide to do that saw cut. It'd be really hard to drill this manually. So these are some examples where the power of PSI in complex deformities with revision surgery, even on standard tubercles it works, but certainly on more complex tubercles it works very well too. And this was the final construct there, what it looked like there. So in conclusion, I think PSI is enabling our toolbox, our armamentarium of osteotomy just to grow. Right? We started coronally, then we went sagittally, then now we're doing tubercle, and now Rick's going to teach us of how to look about rotational plane. And really, I guess the best place the last place you ever want to think is the OR. And that sounds like a hatch has been adopted by the Ranawats. Thank you very much.